Welcome back to another exciting episode of Finding Peaks. I was actually thinking about this before this started, and I always say exciting episodes of Peaks.
Yeah.
Like as if people are just...
Yeah, like just can't wait.
More, Brandon, more in the background. So I hope it's as exciting for you as it is for me at the end of the day. So exciting episode. We talked about it a few weeks ago, or at least I promoted it. Joined today with medical team members here at Peaks Recovery Centers. Dr. Ryan Johnson, MD, and he is our medical director and director of nursing. Callie. Callie, I am spacing on your last name. Kintz, thank you. I was going to say Kynes, so I'm glad we got that addressed. I'm new to this, everybody who's watching at home. Day. Chief Operating Officer Clint Nicholson, everybody.
Hello, everybody.
So very excited to be joined by the medical team. I think they've got a lot of great things to help educate on in regards to medication-assisted treatment, or MAT, as sometimes you'll see the acronym out there in the world of the addiction treatment space. And so in good fashion, let's kick this off with, what is medication-assisted treatment?
Our friend Matt.
Our friend Matt.
Yes.
Who is Matt? We'll find out.
So MAT is medication-assisted treatment, and it's a program that we've implemented recently here at Peaks to kind of target the cravings of an individual that comes into our program, specifically for alcohol and opioid use disorder. So.
Swift and to the point.
Wow.
Way to deliver that. So I guess in this way, let's complicate it a little bit. Let's nerd out a little bit with you, Dr. Johnson. How does that work within the brain? What are we looking at here?
So the point of it is to cut cravings. People crave less, they use less. And so the first question people had to figure out is, what is a craving and what's going on with it? So when we have something pleasurable in our body, a pleasurable experience, like we climb a 14er, we win a marathon, we have a spike of a chemical called dopamine in our body. And it's basically the pleasure chemical. Addiction hijacks that chemical. So it usually hovers, let's say, a range between 5 and 25. 25 is when you win the marathon, when you have sex, when you win the lottery. 5 is kind of what you need to get out of bed. Not all, but almost all chemicals drugs of abuse cause that to spike irrationally high. It goes up to 100, something you can never get in real life, and that's why people love it. That's why they go after it. The medications that we use cut that craving. That craving is a memory of that initial event of that drug use, and when we have that memory in our brain, we actually have a spike of dopamine again. Just a little spike, but it's just enough for our body to completely remember exactly what it felt like. And we crave, and then we go back and we relapse. And so the medications are supposed to stop that. And so there's two different ways they can do that. One is what Suboxone does, which is it binds to that dopamine receptor in a way that keeps it from going up higher. Right. It kind of gives you a little bit of that satisfaction all the time, and so you don't get the big burst. And the second way is just by preventing that dopamine spike, and that's what the medication naltrexone does. And they just work very effectively in different ways.
Wonderful, beautiful explanation.
That was great.
Yeah.
I liked it.
Yeah.
Box it up.
Anything
That's a wrap.
Right? You're welcome. Anything you want to sprinkle on top of that?
No, I think that's great. That explanation of the craving state is fantastic. And I think from when you're looking at it from a behavioral standpoint, when you're getting these spikes in the brain, it is really motivating you and really activating you to go seek that 100 level again. Right. Yeah. And so from a behavioral standpoint, MAT helps to sort of, by mitigating those cravings, helps to reduce those like drug-seeking behaviors, reduce risky behaviors as far as going out and seeking an illicit way to achieve that high. So,
yeah. So, for Peaks Recovery in particular, going back 2 years ago or prior to 2 years ago, so the first 5 years of our company, we operated very similarly to the way that this industry operates, that those things are, in a way, stigmatized because they were adding to the problem or seemingly adding to the problem, right? If we gave someone Suboxone, it's like, well, they're craving and now it's another drug and, you know, they're using it. So the cycle, you know, perpetuates in that regard. So we had pretty hardened philosophy about this, but I think that, you know, from, you know, really the implementation of our detox and you guys coming on board in early 2020 and moving away from that model, I think we've seen a lot of extraordinary things, you know, namely, you know, lowered AMA rates, and we've been given a lot of insights to this, but one of the things that I think that we've done a little bit differently maybe than some other centers out there who are, you know, bringing MAT into their program, and we're not just treating it as an ambulatory thing, we're treating it in-house as an inpatient program. And so, you know, maybe for the sake of time, just highlighting maybe, you know, alcohol use and opioid use, you know, where are we seeing the benefits of starting that and continuing it without dropping them off at sort of a cliff edge in regards to the effectiveness of MAT within residential and stabilization model of care?
You want to do that?
Sure. Well, I'm thinking back to 2 years ago when I came on board and we opened the detox facility in early 2020, and our model of care was very abstinent-based at the time. You have a client that comes in maybe with an opioid use disorder. They do their 7 days of detox on Suboxone, and our thinking at the time was like, okay, they're done with their taper, so now let's start them on other different medications like antidepressants and start diving in with therapy and whatnot. And what we were seeing over time is just more post-acute withdrawal symptoms. And when they discharge out of our care, maybe the rates of relapse, you know, because those cravings were so high throughout the treatment stay. And so really integrating MAT, we're able to control those cravings and follow them through their MAT treatment. And we're able to adjust those doses based on cravings too. The client has the opportunity to meet with a provider and talk about, you know, where they're at in their treatment, and we can adjust as necessary. And then furthermore, with opening our IOP program this year, we're able to continue that MAT treatment through IOP, and that gives us the ability to more time to case manage them out and find them good resources in the community so that they can continue on this MAT treatment program for as long as they need. So I just think it's such a turnaround that we went from abstinence-based to more of a harm reduction model just because we did research within our own facility.
I think we really saw the benefit of early Suboxone in our opiate users, because after getting on their last day of their taper, they wouldn't say I want to use, they'd say I just want to leave, I don't want to be here.
Right.
Absolutely. And
yeah,
they would,
absolutely.
And they would bolt, and they didn't even recognize themselves that it was craving. And so we found just doing a low dose of the Suboxone, 2 milligrams, 4 milligrams, was enough to keep them engaged in treatment throughout the stay.
Absolutely.
Yeah.
And it helps to change that narrative that used to be, well, they're just not ready, right?
Yeah.
I think that's what we would always go to, and the industry would go
Absolutely.
to back in the day is, you know, you get somebody on day 7 of their taper, and those craving states are so intense, particularly with opioid users, that they're going to go, they're going to leave because the brain is literally telling them to go use. It's almost to a certain degree demanding that happen. And so when they would leave, they would pack up, go. And, you know, I think in the industry up until that point in the abstinence-based world, there's this sort of mentality of, oh, they're not ready, they haven't hit rock bottom, you know, and so we would kind of throw our hands up in the air and say, well, hopefully they don't die when they relapse and we get to see them again.
Yeah.
And now we see them a week after that, after we started, and they have hope for the first time ever.
Right.
And
Absolutely.
it's awesome.
And I also think with the MAT program, you know, you just talked about after 7 days, I'm out of here. The prevalence of fentanyl in our society
Absolutely.
is so huge. Somebody could do 7 days of detox, those cravings are high, they go out and they use, and we don't know what's in the substance that they're using.
Absolutely.
And it could be fentanyl laced to the point where they could overdose, coma, and possibly die. So keeping them on this MAT program to control that risk of AMA and possibly using unknown substances is huge as well.
And a lot of people don't know that the MAT medications themselves actually help to prevent overdose. You know, the way that they're designed, particularly Suboxone, which has an opioid component, and then it has basically an naltrexone or a Narcan component to it. So it does help to decrease the risk of overdose if somebody does use, in addition to mitigating withdrawal symptoms, in addition to mitigating cravings.
Right.
So it really is a really powerful medication that allows people to, again, because of you don't have those behaviors that go along with cravings, people start to live normal lives.
Yep.
You know, they get to actually go and start to build a life within society that allows them to be successful and be productive.
And it gets them out of their habits. They're using habits. They develop a healthy lifestyle.
Absolutely.
So the Suboxone is not a forever tool, but it's a great tool for the first
It's a
3
great-
years of sobriety.
Yeah,
Absolutely.
great stepping stone.
So what do you think is essential in running, a sophisticated medication-assisted treatment platform, right? Because at the same time, too, even though the ideal maybe, dosages for residential care is 4 milligrams, 2 milligrams, at the same time, we're going to run into patients who are going to say, no, I'm better at 8, 16. I don't know what the full doses in between are, but, what does it take to really nurture that from a programming standpoint?
You got anything to say for that?
I mean, I personally think it's our wonderful providers. They spend a lot of time with the clients. They meet with the clients multiple times a week, and they really check in and ask those difficult questions and really allow the client to open up and say, because sometimes people may downplay how they're feeling, right? Whether it's they're embarrassed or they don't feel like talking about it. And I just think the providers that we have at Peaks really have that gift and talent to ask those difficult questions and pull those answers. And just having them work together, provider and client, figure out what is an appropriate dose, and then also following up after that. So I do think you guys are a huge component of why it's successful.
I mean, I think there is truth to that, because I think that the clients feel cared for. They feel someone wants to
Right.
help me actually get off of this drug I'm using. And so listening to them and trying to tailor it individually for their needs, I think makes a difference.
Yeah, I'm sorry. No, that tailoring component is huge,
Yeah.
and the sort of recognition that when somebody is in a residential facility, that dose may actually be lower, and they may be sustained on a lower dose because there are a lack of stressors, right? They're in a sort of bubble that allows them to really, in the very early stages of healing and stabilization, once you leave that bubble, those stressors increase, and so those cravings and triggers will naturally increase with it. So being able to meet with providers who will listen to the client and will be able to adjust those doses appropriately, given the fact that, life happens,
Right.
and as life happens, triggers, cravings, all of those things do increase. And so I think being realistic about that and being able to have these sort of ongoing conversations in which there is a real, it's interesting that a sophisticated MAT program is really a relational MAT program when it gets down to it.
Yeah, absolutely.
Yeah.
And, kind of in the host seat operating here, thinking of like, where do I want this to go? In a way, because I'm advocating for how not only addiction treatment centers can behave more responsibly, but better engage with care and provide quality of care, not just access to care, but the word that's coming up for me certainly here is access to care. Having providers on site, dedicated medical staff members allows for that continuous access in a way that promotes quality over time. And I think that's just resonating for me, and certainly something that I want to say, because it's, again, what I want families to hear out there who are listening to me as the host within, the Finding Peaks episodes, is to be curious how these treatment centers are working again, because at the end of the day, you can call any one of us, and our admission teams are awesome, and they're going to tell you we have everything available to this, but it's just not always true and to the point. And if you have a loved one who is suffering from an opioid use disorder, for example, 96,000 people last year died of overdoses related to opioids in that regard. This is a serious thing that's taking place, an epidemic, overshadowed by a pandemic at times, but it's a significant amount of people that are dying, all the time now as a result of this. And so accessing care where there's quality being provided supports and mitigates those risks, post-treatment in that regard. So I'm off my tyrant here, my tyrannical tear here. Moving back into the episode here. So what are some of the, we use MAT, or I think we think about it a lot in terms of alcoholism or opioid, use in that regard. So what are some of the medications that are used? Maybe we'll start with alcohol and then move into opioids, and then, what makes them effective in that regard?
Yeah, so inpatient, we use naltrexone, which is actually like an opioid antagonist. So it just blocks the effects, which also works for alcohol, to reduce those cravings. And a lot of our clients do start on naltrexone, and as they move to the end of their treatment stay, we also offer a long-term injectable form of naltrexone called Vivitrol. And so that just is more convenient when you're out, when you discharge and you're back to normal life and getting going. Sometimes it's frustrating to have to remember to take an oral tablet every single day. So Vivitrol is a program that we implement to inject once a month. And so Dr. Ryan is our providers, our Vivitrol providers. So what we do is we get them set up. We educate them, hey, if you're interested, if you don't want to take this naltrexone, you can get these monthly injections. So we get them started on that. We give them their first injection. If they continue through the IOP program, we continue the injections for them, but ultimately set them up with another Vivitrol provider so that they can continue to get those monthly injections. And a lot of patients just find that really convenient.
And the great thing in alcohol for that medication is it actually does two things. It helps with the cravings, but it also helps if you do drink, if you do relapse, it doesn't feel as good. It blocks some of that pleasure.
Yeah.
So your relapse lasts less long, and you return to sobriety quicker.
Absolutely.
So in regards to opioids as well too, we have buprenorphine and Suboxone, and I think those are common subutex, common language that's used to, of course, to describe the medications. But within that, I think we have Sublocade as well too as an injection, right? And so what are sort of the trade-offs that we see benefiting, not benefiting in regards to Vivitrol and Sublocade from a provider standpoint?
Not following you.
Okay, that's fair. That's fair. So,
Pointed at you.
I guess if there's insights that can be added to the notion that, right, that we see hesitancy around Sublocade, right, because it's an injection, it lasts 2 to 4 weeks, depending on body size. Vivitrol works in a very similar way, 3 to 4 weeks, depending on.
So just a disadvantage to injectables is what you're asking.
Yeah, or tension maybe that you're seeing when you're sitting with patients, and the tension that arises versus Suboxone, Subutex taken daily, whatever the case might be, versus those sort of long-term regimens.
I think part of it is if there's any part of them that still wants to use, if they're only 99.5% sure, that 0.5% fights it.
Yeah.
Because they want to be able to get off and use again. And so it's kind of an early sign that they might not be fully in yet. But additionally, there's a huge cost difference. If your insurance doesn't cover it, it's absolutely not affordable by private pay. I mean, I think it's like $1,000 a month for those shots. And the pill version is reasonable. So sometimes it's just a cost reason why we have to continue the pills. Sometimes the shots are too uncomfortable for people to want. I mean, it puts a little lump under your skin because it's a depot, so the medication is there for a month and then just slowly dissolves. But I think in all cases they work better. The last thing is there's sometimes a provider issue. If you're going back to Washington, we can't always find a provider we know is going to provide it where you are.
Yeah, the access to naltrexone and Suboxone we feel is a lot more prevalent when we're discharging and case managing somebody out versus injectables. So there's an advantage versus a disadvantage to both.
Yeah, absolutely. And there's I think also like a behavioral component that's there as well, as far as what if Suboxone is better for you, or if Vivitrol and naltrexone is going to be the better option for you. I think that at different times in your treatment and at different places you are as far as the commitment to sobriety, either one of those can be a better option. And I've seen them used really well together as well, where somebody does a Suboxone regimen, which the recommendation is a minimum of 2 years, actually. So 3 years has a tremendous amount of efficacy. A year would be the minimum that we would ever really recommend, but typically it's a 2-year regimen. And then after that time on Suboxone, then going to Vivitrol as another sort of way to, almost like as a step down in the level of care and sort of managing cravings and symptoms and almost giving another safety net there.
Gotcha. So the enrollment period or the time that's needed, there is, I mean, I guess it's independent per individual, right? But at the same time too, maybe what I'm hearing there as well too is just the concept of neuroplasticity and new neural pathways that support the healthier side of the brain with that supporting cast being, Suboxone, naltrexone, or otherwise. So so those are big time frames, but are there any like identifiers for which like you can look at, year 1, 2, 3, or whatnot to say, yeah, this is a good point to kind of step off this and move into a different direction?
So the only problem with the naltrexone, the Vivitrol, is it doesn't protect against overdose.
Right.
So anybody who's using medications off the street with as much fentanyl as there is around, I'm not comfortable pushing the naltrexone, Vivitrol in them. You want the protection that the Suboxone provides.
Which is the naloxone
yeah.
that blocks.
Right. And you really, I mean, for those, you really actually want some level of stability when you're starting to engage in those medications, because again, the risk is, there are added risks actually, even though it may be more convenient and it may, in the sense that it's a 30, once a month kind of thing, but there are risks that definitely start to present if somebody is still actively using.
Yeah. And so opioids and alcohol are in their use, can be very deadly, of course. Long-term use, even one-time use with fentanyl laced within it. Meth and marijuana, THC present, I think, different types of problems. They're not as high risk for, death in long-term abuse, short-term abuse, but at the same time, it's still a patient demographic that's suffering in a variety of ways, but it doesn't seem like that we have a lot to kind of throw at them differently than those prior, 2 substances in that regard. And so kind of, when we pull the pot out of them for the first time, right, and they can't use it, they seem extremely irritable, by comparison, right? And maybe a meth user has to sleep it off, but they wake up irritable in a similar sense of things. And so, in that regard, it's not a harm reduction approach. There's nothing significant in the way as far as death being imminent, maybe on the other side, but what are things that we're utilizing, today that can support those individuals in a way in which they're vividly suffering in those early moments?
So, I mean, that's kind of 2 separate questions. The marijuana, there isn't any FDA MAT medication for it. We control their anxiety through medications, through therapy, and that helps because usually anxiety is a trigger for the marijuana use. Gabapentin is commonly used as an MAT for marijuana. It's been shown to have a little efficacy. And actually N-acetylcysteine, which is just a supplement, has been shown in young kids to help with marijuana. But as far as methamphetamine, cocaine, those are the medications, or those are the drugs that bump dopamine directly. And there's one medication that's not FDA approved, but makes sense that we use, and that's Bupropion or Wellbutrin, which just, it releases dopamine. And so after people have been using those medications a lot, instead of sitting at the 25, which is normal, they're down near 0. And all the Wellbutrin does is kind of get them feeling normal again. So it doesn't block the craving state, but it helps them normalize a little faster, is the thought at least. The kind of innovative thing we're looking at is TMS. That's transcranial magnetic stimulation.
Transcranial magnetic stimulation, yeah.
Which was new to me 2 years ago when I started here. But it's basically this big machine that has magnetic coils that creates magnetic pulses. You put a helmet on people, and those magnetic pulses are aimed at the prefrontal cortex where depression occurs. And basically stimulate it. So you end up with stronger cells, and those stronger cells secrete more dopamine. They create more serotonin, and you just end up with people that normalize again a lot faster than they would have otherwise. And we're seeing definite improvement in people with that.
So one potential avenue then for innovation in regards to the methamphetamine users and marijuana users even potentially? Or just stimulant maybe?
More stimulants.
Okay.
But
yeah, absolutely.
As an MAT.
Absolutely.
TMS is definitely it's going to help a lot of our population because depression is a huge trigger, and that's what the predominant, it was designed for, is to treat the depression. And so even though it's not mainstream in the addiction world, I think we are seeing just marked improvement in a lot of patients with it. I think it's a fascinating future.
Yeah, absolutely.
Yeah, absolutely. Well, in that regard, I think we touched on a little bit of innovation there, and we were able to see extraordinary things happening. Certainly, your wife, Dr. Ashley Johnson, is doing wonderful things in the TMS world, and ketamine infusion and those sorts of practices, and would love to continue forward with that innovation and what that looks like, maybe contrasting with, pharmacology approaches in the future. As well too. So for a future episode, we'll invite you back in, bring the docs, the medical team back, and hopefully have a wonderful conversation about potential innovating features of this industry on behalf of addiction and mental health disorders as well too, in that regard. So we'll come back next time. Medical team, thank you so much for being here.
Thank you.
Thanks for having us.
Absolutely.
Good to have you guys. in
Most
the
exciting episode
Very
yet?
exciting.
Most exciting episode
Extremely
yet.
exciting.
Knew it.
Yeah.
And so yeah, as we normally do in exiting here, thanks again for joining us. Look forward to having you guys on future episodes. Chris Burns, Jason Friesman, myself as host. For all the kids out there, check us out on the Instagram. I think we're doing TikTok now.
Yeah. Little TikTok.
We're
Yeah.
pretty much the coolest people ever. Facebook, Spotify, Instagram if I didn't say it. Finding Peaks at peaksrecovery.com. Send your questions, thoughts, ideas, all of that so that we can speak to you guys directly and speak to what's important to you guys in regards to how this industry operates and so forth. So thanks again for joining us, and until next time.